say nothing like making your knees wobble more, right? Anyway, thank you for having me today. I feel a bit humbled as I was sitting listening to the last couple of lectures, and the comment about how intelligent this group is makes you a little bit intimidated, but I think I will be able to offer something a little bit different, maybe bring something different to the table. We're new in general, a new field of medicine. We are new here to Cleveland Clinic, about 2 years old. And I want to explain to you what functional medicine is, but before I do that, I think I'd just give you a little bit of background about me. Interestingly enough, in 2003, when I went to medical school, the second year of medical school, I actually started doing research with an immunologist, Dr. Call, who actually was very interested in primary biliary sclerosis. And so that got me into the liver transplant world and the chronic disease that came along with cholangitis and so forth. Our spin was a little bit different, but it was nice that I had the eye-opening, and then I got the call last year to come and present to you all. I don't have a lot of knowledge base. I'm definitely not an expert like these guys as far as hepatology, but I think from a functional medicine standpoint, the whole idea is to prevent disease or maybe look at things differently with a chronic disease state. So what can we do to optimize the terrain? What can we do from a nutritional standpoint? What can we do from a immunological standpoint that sort of rights the ship? When things are off or out of whack, then our job is to sort of peel back the layers of the onion, look for the chronic and root cause, and maybe help you optimize what you have and improve quality. I started as a family practice physician. I was a naturopathic physician before I went to medical school, so I have a bit of that alternative world, but I was a little bit too left brain science based in my mind and my thinking to embrace that fully. I had a biochemistry background, and so when you put a biochemist in the herbal world, it doesn't really mesh very well. So I couldn't quite find my place. But interestingly enough, in residency, I found Institute for Functional Medicine, and as I sat through their certification to be board certified, as I was completing my family practice residency, they seemed to sort of bring the two worlds together for me. So it was a nice way to look at the body from a biochemical standpoint. We like to say that it's a method of looking at chronic disease by using the basic sciences, the sciences that were taught the first 2 years of medical school, that most of us try to forget a lot of that and move forward, and we keep it as a basics. But we go back in and we pick through it with a fine-tooth comb. We look for a root cause. We try to get down into the underneath the surface. So what we do is we sit down with the patient and we listen to their story. We listen to their story for about an hour and 10 minutes. So we are very fortunate to get to embrace this new model of medicine. This is not normal. When I was in practice, in family practice, the longest I got to be with a patient was 30 minutes, and that was with my new patient for preventive medicine. So here we sit and we get your history. We start at the beginning when you were in the womb, and we travel all the way up into your young, mature age of whatever it is that you present with. And we look and listen for clues. We want to hear your whole entire story because sometimes we miss things. We miss things that might have turned on the system or turned off the system or might have caused some problems and have sort of compounded through the years. We do this by putting things, your symptoms in categories. So instead of, dividing you up into specialty diagnosis, which is what we need to have a stepping stone. So when you come to see me as a family practice patient, I would send you to the hepatologist or the gastroenterologist because I need their wonderful workup. I need them to make sure that there's nothing that I'm missing or that we don't know what's going on. I need the scopes, I need the testing, I need the imaging, I need those things, I need the diagnoses, but that's sort of my platform. That's where I get to start. I then say, well, why is it that you have cholangitis? Why is it that you have irritable bowel disease? Why is it that you have rheumatoid arthritis? Why is it you have all three? Because what we see is usually not one thing. It's usually a conglomerate of things. So in functional medicine, we tend to focus on the base of the tree, the root and the trunk, and the top part are the leaves and all of the ologies and all of the really smart people. That's all. You go to the smart doctors for that part. That's what I tell my patients. And then we come to see us, and we start to dig through what's going on underneath. What's happening? What's driving the system crazy? What kind of deficiencies might you have? What kind of good bacteria might you be missing? So those are the way that we start looking at the patients and their presentation. So we go back to a lot of biochemical testing. And by the way, the slides that are on the zip drive that I'm missing are much clearer, so I'll make sure that you have those. I told them I'd get them to them. But this is the Krebs cycle, and I know it's a lot of blah, 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 even for those of us that have studied it. But the point being is we look at this and we study it, and we actually measure all these biomedical markers, and we look at them and we say, okay, this person looks like that they're having a really hard time going from step A to step B. What are the things that the patient needs to help optimize that? Is it vitamin A? Is it C? Is it magnesium? Is it zinc? Is it none of the above? So do they have too much? And so we start looking at a lot of those biochemical pathways. And that starts to help us sort of pick out some of the areas that we could optimize. Part of the way that we do this with our patients is you spend a lot of time with the doctors. We do some really interesting testing that isn't really your common mainstream testing because it includes a lot of these specialized tests. But then the other part is you also have a team. You have a dietitian that you see. Every visit you come, you meet with a dietitian, and you have a health coach available as well. The health coach is a free service. She's like your phone-a-friend or your lifeline or your accountability buddy. She's also someone that can be utilized as much or as little as you wish. I find it to be a nice part of the team in the sense that sometimes when we have such complex disease states and we have a lot of new things that are coming at us and new information, it's nice to have somebody to ask more questions to be able to call and say, I'm really tired of eating all this really bright, dark green food. Give me some other options, please. And so that's what they help us with. We also look for neurotransmitter pathways. We like to look and see what happens when we have irritable bowel disease, for example. There's a lot of information that indicates if you're low in amino acids or you have even a slight malabsorption going on, then of course then you're at a higher risk for anxiety or depression. So when a patient comes in and they say, hey, I have this primary concern, which could be cholangitis, or it could be rheumatoid arthritis, or it could be something, but there's usually other things going on, and a lot of times there is a psychological component, not only because they've been thrown a real humdinger of a challenge in life, but also because maybe there's some nutrients that are missing or not optimally functioning. So that's what we look for. When it comes to autoimmune disorders, there are several areas that we focus on, not just one. So our hormones optimize and balanced. A lot of times you can't give hormones, especially in end-stage liver disease. We know there's definitely a low testosterone in a lot of cases, but you don't necessarily want to replace testosterone as an example. But what if they're Lactobacillus reuteri, which is a new probiotic that started getting a lot of literature behind it about 3 years ago and really took off last year. But we have a lot of knowledge and suggestion in mice models that they really can rev up that testosterone production. And so that's something very simple, non-invasive, as a general rule, as long as you have the support from the other parts of the immune system and as long as you have the okay from the gastroenterologist, that we can add in some of these good bacteria. So those are just ways that we can help maybe optimize function by replacing some of the things that are missing. Inflammation, of course, how can we control inflammation? There's a lot of spokes on the wheel when it comes to inflammation, hormones, lifestyle, sleep, relationships. You also want to make sure your diet is not highly inflammatory. So there's a lot of areas that we can focus on that will help with that. Infection, is there some underlying infection? Do you have something that's interesting that grows out a lot on the stool cultures? We do a 6-week stool culture, and sometimes we'll see a lot of Klebsiella pneumonia at a very high growth quantity. And so it's not necessarily bad to have strep pneumoniae, but it is when it's in a very large growth status. So if we can knock that down just a little bit for a short term and then allow the probiotics and allow the environment of the gut to sort of remedy itself or right itself, achieve better homeostasis, then we see that we find a lot less inflammatory biomarkers like CRP levels and acid rates and inflammatory interleukin 6 and 10 that will come down on lab values. So decreasing stress, well, we all know that. Take a big deep breath, don't drive to Chagrin and try to hurry back and to give your PowerPoint, because that's definitely not the way you do it. But the point being, stress definitely drives and can alter the immune function. I give a recipe and a prescription, actually, of 10 minutes daily deep breathing, and it's not really an option for my patients, and I will hound them every time I see them. So, how's that deep breathing going? Usually I have a blank stare, but after about 3 or 4 times, and I educate them on the importance of it, it does help alter the cortisol levels. Cortisol, of course, does play a role in immune function. So we find that very helpful. It's something that's quote unquote easy, not so much easy to implicate, but easy to prescribe, but it is at our hands and it is within your control to do. Toxins, sometimes that becomes plays a big role. We do some testing that would maybe have biomarkers. For instance, that we have a metabolic byproduct that is found when a person has a large level of something called MTBE, which is a petroleum chemical. If that marker is really high, then it's just a suggestion to us that there's a possibility that we're having some difficulty clearing some of these petroleum chemicals that we're all exposed to in the environment. It's not abnormal, but how can we best support them to clear that? You know, increasing hydration, making sure bowel function is daily and regularly, making sure that you don't have a lot of, you're not getting exposed to it excessively. Another one is a styrene byproduct, which is a plastic byproduct. But if someone is drinking out of plastic bottles or eating in plastic food, and we see that level being really high, that's something that we can say, hey, I don't know what you're doing, but it looks like you're really being exposed, so this is what we should do. Take this out and don't heat up in the plastic Tupperware, or, you know, et cetera. So those are some of the things that we look at. And that's why we love to have the leaves of the tree given to us. We love those diagnoses. We need that very much. But then we try to start picking through the other parts of the disorder. I thought I'd just demonstrate this. I don't personally have a end-stage liver failure patient this year or last year, so I picked an autoimmune disorder just to demonstrate how we would work it up, what we could do to help complement their process and their disease state. This gentleman, a 32-year-old male, had 5 years of rheumatoid arthritis diagnosed and followed with by a rheumatologist. Was having these cyclical flares, and it seemed like it was always in the spring and the fall. Usually needed some high-dose steroids. They had added a biologic medicine a couple of years ago. He continued to be on methotrexate. They started with Plaquenil but had to stop, which is another medicine that's commonly started at the beginning. He had some negative side effects from that, so he stopped that but continued on methotrexate. So his idea was he was going to come to functional medicine, completely stop medicine, which actually that was part of my education. Was it's not necessarily that we want you to stop the medicine. I actually think they're wonderful medicines and they're probably helping you very much. However, there are things we could do to support the system, so maybe we don't need those high-dose steroids twice a year. Maybe you don't need to have the addition of another medication that was being discussed at the time. So he was really excited to at least get to the point where he didn't have the flare-ups and maybe even avoid adding another expensive medicine. The MSQ score is something that we just follow with our patients. It's a medical symptoms questionnaire. It's a very subjective score, but it just gives us an idea how you perceive that you are feeling each time you come in. We're collecting what's called an outcomes data, which is an NIH study, now 2 years underway. But it's looking to see if what we're doing is actually making a difference with chronic disease. So is the out-of-pocket cost for the patient and the cost to the insurance company, is that being helped? And so far the data is really promising. They want another year's worth of data, so we're working on that this year. His MSQ, by the way, was high. If it's above 150, that is what we would call severe. So we did some basic workup. These are all the standard labs, and as intelligent as it sounds like you guys are, you know exactly what they are. But the basic metabolic panels was normal, and the CBC was normal, and his thyroid function was normal. His vitamin D was definitely low, and we tend to optimize vitamin D. And I will say, just a side note, for liver disease or liver failure or malabsorption syndromes, vitamin D deficiency is definitely something that jumps out at us. And so that becomes an important player because there is a huge amount of literature that tells us that vitamin D does help modulate the immune system. And so if we can optimize that D level, instead of just getting you right up to the 20 or 29 or 30, which is the low end of normal, we actually try to push it to 50 or 70. Of course, watching calcium at the same time, but usually that really helps modulate the immune system, helps us lower the inflammation. His testosterone was low at 233. Anything less than 300 by Medicare standards is usually okay to replace. Wasn't really keen on replacing him with testosterone. He was a young man, and I actually thought, in this case, I thought, if we could do some other things, if we could make sure bowel function was okay, lower inflammation, we could make sure that the whole HPA axis was optimized, then maybe he wouldn't need the testosterone, or maybe he'd feel better. We got him exercising after he started feeling better. So that's where we went, and I said, later, in about 3 months, if we're not better and that level's not up, then we can talk about replacement. He was kind of bummed, actually. But I do try to do less is best first, and then we can go into using more things if we need to. Interestingly enough, food IgG, this is a very controversial test because it is not a diagnostic test for allergies, and though a lot of patients tend to want to say that, oh, Dr. Herb said I have an allergy to wheat or whatever, that is not what this is testing. This is merely a test to tell me whether or not something you may be eating or being exposed to is mounting a bit of an immune response, a stranger danger response. So less than 2 by Cleveland Clinic's lab is supposedly normal. We tend to give a little bit of wiggle room because people like to eat the same thing every single day, so you're going to get a higher response. So we say less than 10. And so for this gentleman, unfortunately, though, a casein, which is one of the primary constituents, proteins in milk, was 48, so it was clearly positive, and clearly a big signal to the immune system that, you know, this food is creating a lot of antibody response. And then wheat was 59. So we actually did go ahead and send him back to gastroenterology and ask them to do a celiac test. Whether they decided to do a brush border biopsy or not, I'm not sure. He was still eating wheat, so that I would think that was what they probably did. But we did go ahead and take him off of those 2 foods for about 12 weeks to sort of lower and dampen that immune response. It's one area that we can control. It doesn't mean you're allergic to it. It doesn't mean you cannot eat it. You can actually eat it, and nothing's going to happen. You don't need an EpiPen. But you may have some joint pain increase. You may feel a little bit more tired. You may have a headache. You may feel achy. Those are just signs of an immune response that's a little bit on the high side. And so we took those out because that's something that we can at least follow, test, and have within our control. The stool test showed a low Bifidobacter species, which is one of the good bacteria. The other one that we test for is Lactobacillus species, and they're a group that we test for. And so his was fine, but his Bifidobacter species was low. That one has a lot of literature that's supportive for IBD and IBS, and so it was important to go ahead and try to replace that the best we can. We're not really sure. It's a new field. The microbiome film is hugely and growing very quickly, but we're trying to stay up on the literature and replace that the best we can. It seems to be helpful. Klebsiella pneumoniae was also positive in this gentleman. I couldn't remember if that was him or not, but at 4+, so basically 0 is normal, 1+ is mild, and then it goes up to 4+ is the highest it can go. And they did a culture and sensitivity to that in Bactrim, and they actually they do usually an herbal sensitivity, just that gives us like 4 things that they check in the lab. Usually, though, none of them are very high inhibition, meaning they don't kill the bacteria very well, so we don't tend to use them right off the bat. But this one had a moderate inhibition to some plant tannins, which is a group category like you would think of green tea, things like that. So dark or even black tea has high tannins in it, so we could increase that in the diet, so that was good. So we went ahead and treated this gentleman. I gave him some vitamin D. I did 10,000 international units a day for about 12 weeks. We debated on the testosterone, and after 12 weeks, we actually did go ahead and give him a low dose. And I said we could do this for 3 months. We'll check your levels. We'll see how you are, and then we'll see if we can take it away. If you do fine without it, then yay. If not, well, we'll have the discussion again. And so I did compromise eventually on that. We took the dairy and the wheat out, much to his dismay, and we replaced the probiotics, and we treated the bacteria in the gut. So interestingly enough, one of his complaints was IBS, but most patients will say, yeah, I poop some days, I don't some days. It's okay. It's not okay. So we want you to have a bowel movement regularly, but it's funny because it becomes a norm, and so nobody complains about it, but that actually was one of his big problems. And so he came back, and after the probiotics and changing the diet, lo and behold, it's nice to have a bowel movement every day, and how much better we feel. We did increase his exercise and deep breathing. I really, really, really think that plays a huge role in any disease state. Even those of us that feel like we are, quote, healthy, I still think it's a good practice. The other thing that we actually did is we helped him with his sleep, but we used melatonin, and we used this slow release. I will say that the regular melatonin, the instant release, has about an hour and a half half-life, so it tends to not work very well for people. But melatonin's role would be a deep restorative sleep. It is not a medication or a supplement that helps you get to sleep or fall asleep. It's actually something that plays a role in deep restorative sleep, deep REM sleep. So we did that, but he slept okay. That really wasn't the issue. I also pulled it out because it's also another one that helps with the immune modulation, and also there's some really good studies out of Mayo, actually, that were done in animals, and they were measuring some of the inflammatory chemicals, the cytokine chemicals, and they were watching to see if melatonin made a difference in lowering some of that inflammatory process. And it was really interesting because most of it was gut-related. So that's really why I was using it, but he liked the idea of maybe get deeper sleep, so I agreed with that as well. So that was that. We had a follow-up at 8 weeks, so really not too much improvement. I mean, he's dropped from about 20-some points in his MSQs, so some things were better. He was going to the bathroom more. Joint pain was definitely still bad. We weren't into the season of the flare-ups yet, so as we followed him, though, you can see where I got the nutritional deficiencies, the test back, where we were looking at all the biomarkers and the metabolic biomarkers for his deficiencies, and he was low in several things, so I replaced them. B3 and B6, just a side note, great for increasing the production of our, what I call happy juices, so serotonin, dopamine, those sorts of things, also melatonin, so that was nice. Magnesium plays a huge role in energy production and producing ATP, so we definitely maximize that. And so with his bowel dysfunction for the entirety of his life, he had some B vitamin disassimilation, I would say, and so we replaced that short term. The goal with us typically is replace at a higher dose short term, and then hopefully as you get better, we can then only depend on our food. I will say that our food in our current state is probably not as nutritious as it used to be, so sometimes you'll stay on like a maintenance multivitamin or something along those lines. But he definitely improved. His CRP level came down, and we made it through one season, and then I just saw him back on Monday last week, and we made it now through 2 seasons without any steroid pack, any flare-up, and we have not added another biologic agent. So he actually is doing really well.